You're all very, very welcome, and I'd like to especially acknowledge Gerry's family, his wife Susie, his kids, I believe his dad, his brother are here. You're all very, very welcome, and on behalf of the Faculty of Health Sciences, thank you very much for coming. So it's an absolute privilege to welcome you all here for the inaugural lecture of Professor Gerry Hanna, who joined Trinity as the Marie Curie Chair of Clinical Oncology just last year. Tonight's event not only celebrates Professor Hanna's esteemed career, but also offers us a glimpse into his impressive body of work and I think the energy that he brings to the university. Like many, I think you've seen by now, who end up here giving professorial lectures, Gerry had the benefit of a progressive education, and his was at St. Patrick's Grammar School in Downpatrick, where he was an excellent student, of course, but also was exposed to diverse ideas and outside speakers. Early on, Gerry discovered a liking for science and a liking for people, which I think was to guide his choice of study and career pathway, and I like to think that he still does today. He graduated with his medical degree from Queen's University in Belfast in 1998 and experienced first-hand injuries caused by the Troubles in Northern Ireland, dabbled in cardiology, but was ultimately drawn to train in oncology, which had the personal interaction that he wanted. Or as the Royal College of Radiologists put it, I thought, interestingly, a career built on relationships. That's their motto for oncology. Gerry paused his specialist training to complete the first PhD in oncology in Northern Ireland, fulfilling his goal to combine clinical expertise with scientific discovery. Since then, as an academic consultant in several roles, Gerry's contributions have had an indelible impact on oncology, both in terms of patient care and research excellence. And I have it from the best authority that Gerry, quote, is considered a star in UK radiotherapy, having the clinical credibility to match his research vision. His opinion is highly sought for complex cases, which he navigates with ease, along with many other things. His research has focused on improving survival outcomes, but also emphasizes reducing treatment-related toxicities, among many other themes. Gerry has been lead or co-investigator on dozens of studies and clinical trials, and some of the details are there in the brochure, with over 200 publications, including clinical guidelines. He's been a very busy man. But Gerry, I understand that time management is one of your strong points. You can let us know. Before joining us, Professor Hanna held several leadership roles in globally respected institutions, and among these was his tenure as Director and Radiation Oncologist at the Peter MacCallum Cancer Institute in Melbourne, Australia. During his time there, Gerry led pioneering clinical trials and contributed significantly to our understanding of radiotherapy's role in the treatment of lung cancer. But importantly, it was also noted that, quote, his empathy, his integrity, and his humanity were all evident in his leadership of a very large team of professionals across 5 campuses. Gerry seemed to live life at a much faster rate than the rest of us and to fit everything in that he needed to. His conversation was conducted at a speed about twice the rate of the average Australian is used to, with the result that it wasn't always easy to keep up with the thread of his abundant wit and humour. No pressure. Colleagues are also quick to mention Gerry's clear thinking, problem solving, and leadership qualities. Not surprisingly, then, institutions want to hold on to a piece of Gerry, and he still serves as honorary professor at Queen's University and honorary radiation oncologist and associate professor at the University of Melbourne. And I know that Gerry has a strong commitment to fostering academic collaboration across this island, which is, I think, especially relevant to cancer care and to Trinity's ambitions. Beyond his professional accomplishments, Gerry has made significant contributions to academic mentorship and education. He has supervised PhD students, postdocs, and clinical academic training fellows, many of whom have gone on to make their own mark in oncology. And while his professional accolades could fill volumes, I think Gerry still wears on his sleeve his liking for science and his liking for people. Because those who have worked alongside him describe him as a humble, approachable, and immensely supportive colleague. He is someone who leads from the front and inspires those around him. But for all his professional dedication, Gerry is a devoted family man, married and proud father of 3. He understands the need to put it all into perspective. And again, his colleagues from Melbourne commented, although managing the biggest job in Australian oncology, he was careful that this was not to the detriment of his family. He voluntarily umpired at his boys' Aussie football games on wintry Sunday mornings when most people were still in bed. And when he told me he was going to a school event to see his daughter receive an award for academic excellence, he was definitely misty-eyed. So as Gerry settles into his role here in Trinity and St. Luke's, we are thrilled to have him join our academic community. His vision and ambition for the future of oncology resonates deeply with our mission, pushing boundaries of medical knowledge while maintaining a steadfast commitment to improving the lives of patients. I'm delighted that we have the opportunity to see a window into Gerry's world this evening. So without further ado, it's my great honour to introduce Professor Gerry Hanna and ask him to deliver his lecture From Monotone to Symphony, the Transformation of Lung Cancer Radiotherapy.
There we go. Dean, thank you very much. Provost, Vice Provost, Dean, esteemed colleagues, members of the Hanna family, ladies and gentlemen, it is a great privilege and pleasure to be here this evening. And Brian, I didn't recognise a lot of what you said, but it was very kind, and you forget a lot of bits of life that actually are very impactful on you and on people around you too as well. So tonight, obviously, is celebrating the Marie Curie chair, and Marie Curie herself, I think, is somebody just to reflect on for a short while. She was truly an outstanding person, outstanding woman, outstanding leader, and outstanding scientist. And as we all probably know in this room, she won the 1903 Nobel Prize for Physics alongside her husband Pierre and Henry Becquerel, who for the discovery of radioactivity. But it's worth thinking she started off in Poland, and her family were quite a wealthy family but fell into very bad times. And to try and raise some money, she did a lot of teaching of English to immigrants. They came to the house and she taught them English and was very kind to them. And she raised enough money to send her own older sister to study medicine in Paris. And hence, sister went to Paris, and when she had enough money raised, she too also went to the Sorbonne in Paris to study physics, and that's where she met Henri. And of course she fell, or Pierre, sorry, before they said that. That's not fake news, by the way. But her husband Pierre, she fell madly in love with Pierre, and they were very besotted with each other. They were very passionately in love, and very tragically, Pierre died. He got run over by a horse and cart in Paris, and she was broken-hearted by his death. Pierre was very kind to Marie. She made sure she was recognised, because in the 1903 prize, the Nobel Committee had only invited Henri Becquerel and Pierre to that. He said, I'm not coming unless you also co-awarded to my wife. She's done most of the work. She needs to be recognised. And I think that recognition was very important. But she was very broken-hearted. She, after his death, she went on to do many things, including setting up X-ray stations during the First World War for injured French soldiers. She made many discoveries after. And also worked with 2 of her daughters, again, in science after. And a truly amazing woman. Sadly, the radioactivity caught up with her, and she died of aplastic anemia in 1934 after being very tired. Now, Belfast has bizarrely a connection to Marie Curie. That's news to a lot of people in the audience, but this is the pneumatic, and the pneumatic took the reason why it's in Belfast is it took the last passengers out to the Titanic with the last boat to meet the Titanic as it sailed off on its fateful voyage across the Atlantic. But Marie Curie also sailed in that same tender as she went in 1921 to the US to raise support for research. How different times have changed. We've heard last week what's happened to NCI in the States and how that's been rolling back. But here was great science being funded out of the States. So that's our connection in Belfast to Marie Curie, and it's quite a nice bit of history to have there. Of course, tonight, we also remember Prof Donald Hollywood, my predecessor, who was the Marie Curie Chair of Clinical Oncology from 1995 until 2013. He was President-elect of ESTRO, and he was also the lead author in the Hollywood Report, a report that transformed radiation oncology services across the Republic of Ireland, made a huge difference. And he also established translational and clinical research at Trinity College and also at the St. Luke's Network. I found these cuttings in the St. Luke's Library, I was sitting there one, and I just came across this folder. And inside of these old press cuttings of Donald when he was appointed in 1995, and it talks about his ambition for research and also succeeding Dr. O'Halloran. And Dr. O'Halloran the chair had been vacant for 8 years between Dr. O'Halloran and Donald, and it's been vacant 11 years between Donald and I. Hopefully not be as long for the next person after that again, but here's hoping. Interest is also were cutouts about problems in ED or NE as it's called then, plus ça change, as they say, as time goes on. But anyway, that was Donald. We remember Donald very fondly. He was an outstanding leader, a wonderful person, a really true individual, and he was greatly missed. But of course, Radiation College in this island is the better for it. Now, we entitled this talk Monotone to Symphony. It's a bit kind of you think, what was he meaning by all this? But I think what I want to show is that we've gone from very simplistic approach in lung cancer to something that is really expanded beyond all recognition. And the early support that we have of lung cancer being treated by radiation is by this chap called Ralston Patterson. And you may know Patterson because his name is given to the Patterson Institute at the Christie Hospital in Manchester, one of the world's leading cancer centres. And Ralston Patterson did a lot of seminal work in setting up how we undertake radiation treatment, how we do fractionation, some of the safety considerations around it, particularly around brachytherapy too as well. He established a lot of the dose fractionation regimes used. And the publication on the left of the screen is the treatment of malignant disease by radium and X-rays. And that's his seminal publication. But he also published the one on the right of the screen, Rontgen treatment of primary carcinoma of the lung, in 1928. But he did go on and note, and this again is 1948 now, 20 years later, he said there are only 4 cancers that can be cured by radiotherapy. They were cancer of the skin, cancer of the mouth and lip, cancer of the uterus, and cancer of the breast. And hopefully that list has changed quite significantly, and hopefully lung cancer is now established well and truly on that list. So for those in the audience who say, what is actually radiotherapy, Gerry? What do you mean by when you say radiotherapy? Well, very simply, radiotherapy is the use of ionizing radiation to treat diseases. Usually cancer, though not always. We sometimes treat benign disease with radiotherapy, but that practice has fallen away with the risk of secondary cancer. And ionizing means that the radiation deposits energy, usually by the ejection of an orbital electron, into an atom or molecule, and that causes a lot of chemical events that usually cause damage and destruction of the DNA, and cancer cells can't repair that damage while normal cells can. And that's how radiotherapy works. We can all go home, great. But that's not it, of course. And in radiotherapy, what we try and do is deliver the radiotherapy to only where the cancer is and avoid the normal tissues around that. And sometimes we fail. And the reasons for failure are, one is we miss the tumour, and we've tried to improve how we target the cancer by using a number of techniques described in that slide. And we also try and overcome the natural resistance of the cancer to radiation, what we describe as radioresistance. And we do that by different ways, giving different doses of radiation, giving different fractionations of radiation, also shortening the treatment time, and also giving some drugs alongside the radiation that help sensitize the tumour to radiation and make it more effective to the tumour itself, and hopefully not more effective to the normal tissue cells. Now, radiotherapy since the days of Patterson has evolved massively, and there's a lot of technology described in this slide, going from very simple, the very first LINAC. LINAC stands for linear accelerator, where we accelerate electrons that create very high energy photons that treat patients. And that first LINAC was used clinically in 1960, and now we have a lot of other technologies come the far end up to the present day. And that's really changed what we do. We're much better at shaping radiation around the tumour and avoiding normal tissues. And I got into it in my PhD, and my PhD was in PET-CT for radiotherapy planning in lung cancer. And Michael McManus, who's on the left of the slide, he and others at Peter Mac in Melbourne, way in the late 90s, had one of the world's first PET scanners. And they worked out that people who had PET scans before treatment for radical lung cancer did better than those who didn't, simply because we knew better where the cancer was. We were able to either take out the cancer more accurately, or we excluded those people who shouldn't get curative intent treatment because the cancer was widespread. We took that bit of research that Michael had done, and we took it in Belfast, and this is thanks to some people in the picture on the right of the slide. I want to single out Professor Alan Hounsell, who's in the audience tonight, his wife Catherine, who's beside, who's also here tonight. Thank you both for coming. And Ruth Aiken, Zafra Hassari, who's from the West Bank, David Stewart, who's in the pink at the back, Viv Cosgrove, who's now in Leeds Physics, the heads up Leeds Physics team, and Professor Joe Sullivan at the back. And we took a clinical trial and we used that to say, how might you use PET-CT for radiotherapy planning in lung cancer? And we had a really wonderful 3 years examining the different, how not to use it, what are the limitations, how it should be integrated in clinical pathways. And that was all thanks to really work that came out of Peter Mac, unbeknownst to me. It ended back in Belfast, and we took that forward. And of course, my 2 PhD supervisors were Joe and Alan, and without them, I don't think I would be here today. Joe particularly, who encouraged me to do a PhD, and I thought, why on earth would anybody spend 3 years of time doing a PhD? Well, it was the best 3 years of my life, and I would encourage any trainees here tonight to think about that. A PhD brings you to places you'd never expect, so do consider doing a PhD. Alan, who taught me how to really trained me in the scientific method. And a PhD is not about the research, it's about training the individual. And Alan really did give me that training, which is fantastic. And the third person in this is Paddy Johnson. Now, Paddy didn't do much training for me, but he got the money was the big thing. And he funded the PhD. So I have to say a huge thank you to Paddy. Of course, we miss Paddy terribly since his early demise too as well. So I did my PhD, and towards the end, I was very lucky to get the RCR Keith Durrant Travelling Fellowship. And myself, Susan, the kids, we went off to Amsterdam. James wasn't with it, it was just Alice and Patrick then, and we had a wonderful time in Amsterdam, taking some lovely snacks. You see the lovely cheeses that are there, and I went to VU, which was really the world leading centre in stereotactic body radiotherapy, and I took a fellowship there. We researched how to do 4D PET-CT and all the limitations of that, how to put those two techniques together, and create some flows of pathways around that. Suresh Senan, who's in the middle of the screen there, was my supervisor. Suresh was really fantastic again, another great person to have met along the way. But I shared an office with Femke, and John, who wasn't really our office mate but never seemed to leave the office, was also there too as well. And we had a fantastic time in Amsterdam. But it was really, again, another great grounding, great experience. And the idea was really to take that stereotactic experience and bring it back to Belfast. And we set up from that the first stereotactic program in Northern Ireland. I then went on to Houston, Texas, which was completely the opposite of Amsterdam in many different ways. And I had a fantastic fellowship funded by the Friends of the Cancer Centre, the Pearl Ewing Fellowship, and that was in breast cancer, looking at things like deep inspiration breath and trying to move the chest wall out to avoid radiation going to the heart. Tom Buckles, who's there at the tie in that photograph, had supervised that. It was really a great pleasure to meet Tom. Whilst I was there, I stayed in a kind of those residence inn places, kind of a low-cost thing, the best I could afford at the time. And they had this waffle maker that made these waffles shaped the size of Texas. I always remember this one chap who wandered in, and he said, son, as he put his waffle, he said, I'm just about to eat the whole state of Texas. And I thought, you probably could too. But anyway, that was Texas. And I came back to Belfast, took a consultant job up, and missed an opportunity to become a senior lecturer because I chose not to, which was probably, looking back, maybe something I should have done, but that's water under the bridge. But I thought, that's research done. I'm going to settle into an NHS career, deliver good care to patients, and do what clinical trials as I can. Then the IAEA contacted me out of nowhere and asked, would we be involved, because of the work in the PhD, on looking at consensus guidelines on how to use PET in routine clinical practice. And that led to this consensus report where we published, it took a couple of years to get through, but how to use PET-CT for radiotherapy planning in routine clinical practice. And this photograph here with all the flags is in the International Centre in Vienna. It's where they bring everybody to get their photograph taken. You can see the Irish flag sitting there in the middle. And of course, these are all PET experts from around the world. It really was a phenomenal place to go to. This then led on to us, with the IAEA, running a clinical trial in 10 low and middle income countries. And this nearly killed me for a range of reasons. But it was trying to harmonise very different healthcare systems, people who had different backgrounds in radiation training, and how to do this best. And again, the photograph you see with me holding the hat is again the Vienna International Centre. It was a bit like the stage. I don't know if you ever watched Thunderbirds. There's a massive big fountain with all these flags around it. And I almost imagined a rocket would come out of the middle of it, but it never did. But in this study, we ran a clinical trial to see if we trained these centres to do
do radiotherapy planning as we thought best, with the use of PET-CT and using the guidelines we published. Would this really make a difference to patients? And what we did is, you see the light blue line is above the red line in the survival curve, and it did an improved survival for patients across these 10 countries. And it was really a fantastic collaborative effort. I learned a lot, we all learned a lot together, and that's the team of clinicians from across those 10 countries, from Pakistan, India, Brazil, Uruguay, Estonia, Eastern Europe, Turkey as well, and Vietnam. We had a really great range of countries that delivered that clinical trial. It really was a real joy to deliver. Along the line, we also involved in training interventions to go to countries to improve the quality of care. I know many of the auditors, Mary and Michelle, have done this in different countries too as well, and that really does bring a little bit of our experience to improve outcomes for people who are not as fortunate as ourselves. Excuse me. And so from the IAEA, that was PET kind of done, and we, alongside others, we brought a lot of new technologies in Belfast, including 4D CT scanning, which we needed for stereotactic radiotherapy. This is showing how you track the tumour moving up and down as a patient breathes in and out. By tracking it up and down, you can be more accurate with your radiotherapy. You can then shrink the fields that you use to treat, improving toxicity but also improving accuracy. And Aidan published a lot during his PhD about how the effects of that movement on the effect on cancer cells. He did a lot of fantastic work back in the day. We also brought in daily cone beam CT, and I'll speak about that in a second, but this is doing scans during treatment. So the top image, which is the kind of more black image, is what we call the planning scan. And you can see here the red line is where the tumour is. But when we come to do the first treatment, and this is a CT scan during radiotherapy, or before radiotherapy starts, we can notice that the cancer has spread outside the red line. That means it has progressed from the time we planned it, and therefore we would have missed this. And this is something we weren't picking up before. And this, I think, a lot of these technologies have come together to really improve outcomes for patients. Again, we put that together. And we said, look, one other factor is, human behaviour around all of these imaging techniques. And I call the 7 deadly sins here of local regional relapse. And probably the most important thing is not to miss the tumour. And what we also noticed during the PhD, and this has been published by others, is that when you ask different people to outline where the cancer is, we all do it slightly different. That's called inter-observer variation. It's well recognised. We're all humans. We all do things wrong at times. We also miss bits and pieces. And this is a very interesting paper. This is one from a French group whereby if you ask junior staff to outline the cancer is, they draw very small targets. As you get older and you get more failures under your belt, you draw larger targets. Therefore, you're less avant-garde about what you do. And of course, this is our approach. But the most important take-home of all of this is that when we do radiotherapy planning, we always now, at high critical areas, is get a second check by another doctor to make sure what we've drawn is accurate. And we did a lot of work on this, nearly 10 years ago, saying, how might you do this? How might you do this well? This led to the publication of these Royal College of Radiologists guidelines to say, how might you reduce that human error in radiotherapy planning? And that was really quite an interesting journey. One of the most interesting things about that was about how a team behaved and acted together. And the most important thing was respect, about positive criticism, about support through that, and being able to accept a degree of criticism and feedback and put that into your routine clinical practice. So to some extent, it's a bit like what Team Sky did in cycling in the Tour de France. It was about marginal gains theory, sweating the small stuff, improving little bits, incremental gains, as they say. Now, that's allowed me a little bit of segue into cycling, so I put a few cycling photographs up just to make a little bit of difference. And there's a few curious photographs here. On the very top left here, this is Dr. Seamus McAleer, Dr. David Stewart, myself in Lourdes. This is the Jeanne d'Arc Hotel. This is a famous old haunt of ours. It had the most amazing entrance, but absolutely terrible rooms once you got inside. It drew you in, and then, of course, it was absolutely terrible. It was great for a cycling basis. We went to Lourdes, and we did a lot of the Pyrenees through those trips. And here's myself over the Alps with Dr. Neil Morgan, who's a renal physician from Southern Trust. And Neil, thank you for coming tonight. But Neil and I did a really great cycle over the Alps. And you see this is the call to Madeleine, 2,000 metres. This is actually in San Antonio, Texas. Seamus actually introduced me to a great cycling shop where we used to go in the breast cancer conferences. And this bike was written by Greg LeMond. the day before I wrote it. We rented these bikes out, and of course it was a great bike. We got a puncture after the first 5k, which maybe tells me something about my relationship with cycling. The bottom one is Misenhead to Melonhead. This is the Raid Pyrenean, this one here. We also cycled the Camino, and this is Susan at the top of El Benata, the first hill. Susie thought she'd made the top of the peaks. Little did she know there's several other peaks to go. And of course this is myself and the kids who cycle the Peter Mac cycle, which is a big annual fundraising event at Peter Mac. But cycling, of course, has been central to a lot of oncology and a lot of work we do. Back a little bit to science. So when we give radiotherapy, we normally give it in a fraction a day, and the standard way was to give it over, roughly, if you're trying to give curative intent radiation, over 30 fractions over a 6-week period. Sometimes you can do what's called hyperfractionation, where you do 2 treatments a day, but much smaller fractions, and you break those up a little bit. You can then accelerate it, where you give actually treatment not just 5 days a week, but 6 days a week. And then sometimes you can do what's called hypofractionation, where you give very big doses per fraction, but make smaller fractions. Therefore, you also what's called accelerate the fraction. You reduce the overall treatment time. And these all are ways to try and overcome that radiation resistance that I talked about at the very start. Now, we took that forward, and I was involved in a trial with Professor Corinne Faber-Finn, that's Corinne in the black t-shirt at the top, and we put together a thing called the ISOTOXIC IMRT study. This was a very ambitious study. It took a lot of work, where we threw every technology that we had at the time at planning lung cancer to make it as optimal as possible, and also used twice daily treatments with acceleration for very large tumours. It was a really good trial, and we thought we'd be able to take it into a phase 3 study. But unfortunately, what happened was this study came out and showed that dose escalation was probably not a good thing to do. It caused too much damage to the heart, and therefore patients died from an increased dose of radiation rather than using the standard dose of radiation. And then for that trial never really got off the ground, though I think there was a lot of merit in different parts of it too as well. Now, toxicity of the heart is something that's very important. Years ago we didn't worry about it because lung cancer patients simply did not survive radiation treatment. They didn't live long enough to get any of our toxicities. Now they do, thankfully, and therefore optimizing the toxicity of radiotherapy is now equally as important as trying to improve the cure. And with this study, we did reception work in Belfast, and Dr. Gerard Walls, who's here at the front, who was my ICAT fellow, starting off before I left for Peter Mac, started a lot of this work looking at how might we work out what the risk to certain parts of the heart is from radiation, how might we optimise that, and is there anything we can do to protect it. But what Gerard showed was that the base of the heart, which is kind of this green structure, you see it there in this diagram here, the dose that is very critical, and the more dose you give to that, the more likely the patient is to have radiation-induced heart disease, in spite of other factors such as smoking, family history, all those other factors that give people a risk of heart disease. So he also worked out that the pulmonary veins, a part of the heart that we don't worry too much about, was very sensitive to radiation in terms of causing arrhythmias. And the more dose that you give to that part of the heart, the more likely you are to have cardiac arrhythmias after lung cancer radiation. And this was actually pretty seminal work. And was awarded. We got 2 front covers of one of our leading journals, the Green Journal, in virtually the same year, 2023 and 2024, and that was really quite a big thing. So well done, Gerard, but that was a really seminal bit of work. Coupled with that, we then looked at using stereotactic radiation. So we brought that back from Amsterdam, and we started the first patient got treated in Belfast in 2013. Stereotactic radiation is using very high dose, high precision radiotherapy delivered on a few fractions, but very, very high doses per fraction. And we know that this is better from this Chisel study than standard radiation in lung cancer. It's also really well tolerated. Very few patients get very much by the way of any significant side effects. And people who are very unfit or who are on oxygen can have this type of treatment, get their lung cancer cured, and still be alive a couple of years later, which is something we never did 10 years ago. So we're treating people who are less fit than before. We're also using stereotactic radiation to treat metastatic disease where it's present in very small amounts or in very small numbers across the body. This was a study by David Palmer. David and I also shared that same office in Amsterdam, and David has done some of the seminal work showing how best to use stereotactic radiation to treat what we call oligometastatic disease. At the same time, myself and others in the UK have been setting up a number of oligometastatic studies. And this is a SARON study, and I was very briefly chief investigator of this before I left for Peter Mac in Melbourne, but it's now been led by Dr. Fiona MacDonald at the Royal Marsden. And this is looking at patients who present with lung cancer and have a localised lung cancer in the chest, but have up to 3 metastases elsewhere in the body. And what we did with these patients is we give them chemotherapy first. We've irradiated the primary tumour, we also irradiated the metastases, and that trial has completed recruitment, and we hope the results will be out sometime this year, so stay tuned for that one. Alongside the study was the HALT study. Again, we spent years trying to set this up. This is taking patients who have metastatic disease, but they're on a drug such as osimertinib, a tablet drug called TKI, and up to 5 of their metastases have moved on, have progressed. And normally what we do is we change the drug or stop treatment entirely, and that's it. What this trial does is it randomizes patients to receive stereotactic radiation to those lesions that have progressed. Again, this has completed recruitment early 2024 and is due hopefully to give a signal hopefully sometime later this year. And these are very big studies. They may not be positive, but this is trying to say how might we use radiation in metastatic disease in that way. So we've used our tactical radiation capacities quite significantly. We've expanded those. And some people say, well, maybe this is as good as gets, Gerry. You can't get any better. We've hit the ceiling of technical development. And if that's true, we need to think of something else. So we were beginning to think of that. And we said, look, maybe if we combine drugs with radiation, this could be a better way to improve outcomes for patients. So in the UK, through a group called CT-RAD, myself and others, led by Anthony Chalmers and David Seabag Montefiore, looked at how best to combine drugs with radiation. We decided lung cancer was the place to do it, and we decided that a certain class of drugs were also the class to use. I'll tell you about those in a second. Also, after that, later on, the US teams began to also look at this in a great degree of great detail, and you can see their seminal meeting on that too as well. So we looked at what are called the hallmarks of cancer. So cancer has hallmarks. Started off with 8, then became 10, and now I think there are about 14 there in the slide. And those hallmarks describe certain qualities of the tumour that allow it to evade the normal control mechanisms that all our cells have, and evade those mechanisms and grow uncontrolled, and thus become a cancer, and thus also spread to other parts of the body. But if you look at some of those, look at the genome, or look at the immune response, these are all areas where we can put drugs in that improve the impact that radiation might have, that particular signal. And we published this back in 2017. This is us, by the way. There's a few photographs. Anthony Chalmers is the other chap in the kilt, not me, as myself wearing my Hanna tartan, and Anthony's in his particular tartan as well. Anthony is professor at the Beats in Glasgow and has been a great friend to Irish Radiation Oncology over the years. And this is another meeting where we're all wearing Harris tweed for meeting in Scotland too as well. But what Anthony did was, what we did in this, we said, look, in each of these hallmarks of cancer, what drugs might you put with them? And we decided to focus on this group, which were the genomic instability mutation group, PARP inhibitors, ATM and ATR inhibitors, and look at those. So, and these work by different parts of the cell cycle. So you look at, here's PARP is basically the G1 interface, ATR is the synthesis phase, the S phase, ATM and ATR. I also work on G2 division as well. And those drugs will have different effects on the tumour, but also different effects on normal tissues, depending on how they are combined with radiation. So myself and Carl, we put our very first grant in back in 2014 to CRUK, and we were up against some very stiff competition. It was only for £50,000, but it was really impactful to us at the time. And against the wind, we managed to get this grant where we were allowed to investigate the use of ATR inhibition alongside radiotherapy in a number of different murine models. And my PhD student, my first previous student, Victoria Dunn, Victoria did a lot of the work alongside Carl. And there's a slide there showing different responses. What we're looking at here, if you show, this is the normal cell growth. This is just with the drug in blue. The radiation is red, and this is the radiation drug together. You can see the tumour growth is delayed very significantly by the combination of a number of different cell lines. Now that looks a very simple slide, but behind that slide is literally months and months and months of lots of hard work by Carl and the team in Belfast who do a fantastic job. And this was all supported by Professor Kevin Price, who's well known in radiation biology circles from Belfast, who also co-supervised Victoria with me. But the key thing about this work, we didn't look at just the tumour response. We then looked at the normal tissue of the lung, and we looked at what the inhibition of the ATR alongside radiation looked like in terms of lung toxicity. And the really good news is it doesn't seem to increase lung toxicity together. Therefore, we've got a better therapeutic ratio between the drug and no drug and radiation. This drug then was picked up and we came together as a collaborative. We also showed that if you knock out P10, that this can make the radiosensitivity even more impactful to the patients. So certain tumours, we begin to look to see who might you target it to. So for instance, somebody who has a P10 deletion may respond better to this particular combination. And this was taken together as we set up a thing called the CONCORDE study. And myself and Alistair Greystoke of Medonc in Newcastle upon Tyne, alongside Sarah Brown, who's a methodologist in Leeds, came together along a very large team through CT-RAD to design this study. The novel thing about the study was it set up a platform study at phase 1, putting different drugs alongside radiation. It also control arms to examine the toxicity of radiation, and it also did a thing called a Bayesian design rather than a 3+3 design. It made the recruitment much faster through this. It's a really technically challenging study to set up. And this took us 4 years to set up, and also 2 applications to CRUK. The first one wasn't successful, but the second one was successful in 2018. Just as that was happening, I got a phone call from this place to say, would you like to come and work with us? And later that year, of course, I joined Peter Mac in Melbourne. And because of that, unfortunately, I had to hand the captain's hat over to Corinne there. And this is the front of us. Anybody know what sort of plane that is? Any guess? It's a 787 for any of those airplane buffs out there. But anyway, so Corinne became the chief investigator of CONCORDE and took over this, has taken over this, and it's still running. Jared is on the trainees group, and Carl, of course, the translational lead for that. So I jetted off to Australia and left them all to it, and I went to this place, and this is us arriving with all our bags off the plane from Ireland, from Dublin in 2018. But this is inside Peter Mac, and as I walked into this building for my interview, I looked up to the centre of Peter Mac, and I said, my goodness, this place is serious about cancer. Their building speaks that we are very serious. We nothing but the best is good enough for the treatment of patients with cancer. And it really spoke volumes to me that this was a place that would be a great place to do work, to do research, and to lead radiation oncology from. Not only is Peter Mac a brilliant place, but it's sat inside a fantastic ecosystem of at least 10 or 11 other leading institutes across Australia and the world in their particular fields. You can see it here. And in this, what they call Melbourne Health Precinct, there are 45,000 employees in healthcare or in research working in health. And it really is a powerhouse of research, not just for Australia, but also the world. So you can see it's a very formative place to work, and I really enjoyed it. It was really fantastic in every sense. These are some of the photographs. One interesting thing was, this is of course Christmas in Australia, which did not quite feel like Christmas, if I may say. When I first arrived off the plane, they said it's time to have the Christmas barbecue, Gerry, and they said, Gerry, you as director have to do the barbecue. And here I was, trying to barbecue for 50 or odd Aussies, and I thought the Aussies do barbecues very well. They've left me in charge. It was not a very good barbecue, but I survived my very first mission, and hopefully it was okay. But it really was a great place to work. We also were lucky to be awarded an ACRF grant for again taking radiation research alongside immune combinations, and that's myself and Nicole Haynes, the joint awardees of that grant back in 2020 during COVID. And this also is introducing a talk at Peter Mac. And one of the interesting things you have to do the acknowledgement of country, whereby if I was doing the talk there, I'd say, you're very welcome to this talk this evening, and I pay my respect to the elders past, present, emerging, of the Wurundjeri people of the Kulin Nation. So I did this at one of the SARON meetings, and one of my English colleagues, Fiona, said, Gerry, she says, what was that thing you said at the start of the talk? I said, it was called acknowledgement of country. She said, what's it about? I said, a bit like you go into Scotland, and in the talk in Scotland, they say, we acknowledge the Scottish whose land this should really be, and this shouldn't be English anymore. She said, I get it. So that was that anyway. But Peter Mac was a great place. We did a lot of work trying to bring teams of people together, and this really it was just a runaway success in many different ways. This is what we did this every year for women at Curie to celebrate Marie Curie's birthday in November time. And this is some of our oncologists, radiation therapists, physicists sitting on the steps in Peter Mac. But the whole concept of Peter Mac was that nothing but the best is good enough in the treatment of cancer, and that really pervaded a lot of what they did, both in the treatment and also in the research. And that's something I think all of us try and do in our work every day, in spite of the limitations that many of us face day to day. One thing we had to do was, that department had kind of fallen by the way a little bit in Peter Mac. We had to do a lot of work with bringing them together, and we had over many months came together to really say, what are we about? What's our strategy? Where should we go for? And I think the key thing was actually trying to get everybody to buy into that. I think that inclusiveness where everybody owns a strategy, where they feel part of it, they feel, yes, this speaks to me and I can be part of it, was the thing we really tried to engender and foster. So we did a lot of away days, and these are all the consultants. Just take note, Charles, there are 50 consultants for 16 clinics against our 20-something odd for 14, so they had a lot easier than our team do, but that's a different matter. But they certainly, we kept this phrase, we said that we seek to deliver world-leading radiation therapy for the benefits of patients with cancer across Australia, underpinned by research and education. Very simple thing, but everybody really bought into that particular bit. We also put the education bit, which was missing from a lot of what we'd done before, which is arguably as important as research, or maybe more so in terms of generate the next generation. Well, we did a lot of firsts. We did the first gamma knife treatment. We also did the first cardiac sabre in Melbourne, in Australia, and this is I put this up for a bit of fun. This is the Herald Sun. This is the Australian equivalent of the Daily Mail, and they did a very great press expose, and they had A Blast of Life was the front page. We couldn't believe we got front page coverage, and this was our patient here sitting, his adoring wife beside him, and a rocket to the heart, and it's very explosive language. If you ever get a chance to read it, it's actually quite funny. I enjoyed reading that the other night, but this was a blast of life. Dying man saved by a massive radiation beam to the heart. But it was Australian first, and what we did, the key thing here was to work out from the EP studies, where did the cardiac arrhythmia start from, and to try and deliver that dose of radiation to exactly only that part of the heart at a very high dose. It was a very interesting, exciting time, and I was privileged to be the first person to do that in Australia. But then this thing came along, COVID. That really changed everything we did. And we were very cut off from family and friends, and we decided, look, it's time to go back home. And we went back to Belfast. So we got back on the train, and we got out of Australia from there. And we went back to the Cancer Centre in Northern Ireland. It was just lovely being back home to friends and family, and there's nothing quite like that at times in many ways. I came back to a workforce that had been really ravaged by COVID. It really was. You could see the kind of the burnout that was there at the time. The cancer. We did a lot of work with how did we try and refresh teams. How do we bring people together again in that setting? And how do we also, look at some, really challenging situations around demand for chemotherapy and supply of doctors. How would we be more inventive around that? That took a lot of work. But it was also really lovely to be back to the research team, and of course back with Gerard and Joe and Sneil and Carl. And one thing we did was we looked at ctDNA and how might you use ctDNA, how might you use radiation to release some ctDNA from lung cancers and measure that ctDNA and see what does that actually do. And what we did was took patients and we took blood samples after each fraction of radiotherapy, and we said, what ctDNA can we pick? And there was a spike after the first fraction, and that showed different mutations. We thought maybe this could be possibly used for diagnostic purposes in lung cancer, and that's something we're looking to investigate. We've got a grant from ISAC to look at that, and that'll be work ongoing over the next year. Also, the last while in lung cancer has been immunotherapy, and immunotherapy as a drug has been on the cover of Times not just once but twice, and here you are. What if your immune system could be taught to kill cancer was a provocative question, and of course immunotherapy has been transformative across many cancer types, and we in radiation felt, gosh, that's the end of us then, no need for radiation yet again. And of course the really great song, I'm sure it brings back certain tunes that are very big, Immuno-kill the radio star. And what does immunotherapy do? Well, immunotherapy gets your immune system turned back on again. It gets it to try and recognize cancer as being something foreign and destructive. So as we sit here, we all make cancer cells in our body, and for a range of reasons, those cancer cells don't survive. But one of the reasons is our immune system recognizes those cells as being damaged and being different, and it takes out those cells and kills those cells. And one of the mechanisms is this called PD-1, PD-L1 inhibition, whereby the damaged cell or the abnormal cell says, I'm damaged, kill me, I need to be cleared and so on. But what cancers do is they block that signal, and or they turn that, they put a molecule across PD-L1 which turns that off. It makes the immune cell say, I'm okay, move on, there's nothing wrong with me. But the drugs, what they do is they block that signal from the cancer cell to the immune cell and say, guess what, I'm damaged, please eat me. And immunotherapy has been, one of the key things in immunotherapy is it's improved outcomes for very hard to treat diseases, such as lung cancer. It's improved survival. It also improves survival in the longer term. So people who have metastatic disease forget to actually relapse. And that's been a real game changer across a range of cancers. But it still doesn't treat everybody. And you can see in this early study of immunotherapy, most patients, unfortunately, are dead at 4 years rather than being alive. But what they noticed in some of these early studies is that when you give radiation, that radiation improves the survival with immunotherapy. And this is Keynote 01 study, and this is patients who had no radiotherapy, those who had radiotherapy, and you can see overall survival is improved for those who had radiotherapy and immunotherapy together. This wasn't designed in that study. This was a retrospective analysis, but it showed that there might be some synergy between radiation and immunotherapy, and this has now been well established. And how might this work? Well, radiation comes into the cell, it causes inflammation in the cell, that causes the immune system to be attracted. The immune system then recognises the damage and brings that damage to the immune surveilling cells, and it causes an expansion of CD8 cells. And those activated CD8 T cells then go and attack cancer elsewhere in the body. So lymph nodes might be key in this immune response, and what we're thinking in radiation is that what we might have to do is to actually spare some of the immune apparatus as we do radiotherapy as an organ risk. This is a new concept, one of the concepts we're looking to investigate over the next 5 to 10 years. Also, in Peter Mac, we looked to say, could you image that particular interaction between the immune system and PD-L1 interaction and say, where is this happening, which patients might respond to immunotherapy and which may not. And we did a lot of work with this during the time I was there and afterwards, looking to see, can you actually image that immune reaction. This is work led by Fiona Higgy-Johnson and Michael McManus, and this is a murine model. This is a tumour which is PD-L1 positive. This is a similar tumour which is PD-L1 negative. You can see very clearly the difference. This is a patient who has a PD-L1 positive lung cancer. You can see the bone met there, and you can see it also in his femur on that MIP image of the PET scan. And we hope that this study might help us better select those patients who would respond to immunotherapy. We are also here at Trinity going to use immunotherapy in hard-to-reach areas, again with chemotherapy and radiotherapy together, alongside a drug called olaparib. Remember back those PARP inhibitors we saw in CONCORDE? Well, this is combining chemoradiation, PARP inhibitor, and also NK killer cells. And Melissa Conroy and I have been very gratefully awarded a CREST award by the Trinity St James's Cancer Institute to look at this work and bring this combination forward. Also in our group, in the Advanced Radiation Therapy group, we want to look at certain signals in our CT scan to say, can we detect on the CT scan image with more detail, are there signals or patterns that predict for those patients who'd respond better with combinations of drugs and those who respond better for certain types of radiotherapy delivery. And Michelle and Sarah are looking at these mathematical models, which are radiomics. These require a lot of computing power. And I think in the end, tools such as artificial intelligence will help us solve all those questions or look at those in more detail. And you'll hopefully see some work about that later on. Laura's looking at disparities between genders. You can see one interesting we've noticed in small cell lung cancer is that there's a difference between response rates for chemoradiation between male and female patients. I thought this wasn't a thing, but actually there are quite a few publications on this. And it makes sense because actually if you think about it, the immune system between men and women are slightly different. And that has to be right for childbearing years particularly. So if that immune system is different, there may be a differential response to cancer. We're looking to see how might that be optimized, what are the signals of that, and Laura's work is looking at that. How do we optimize? Patients with lung cancer are very often unfit. They're very often people who've had other risk factors that make them, give them other health problems such as heart disease or COPD. And can we improve their quality of life? And also can we improve their response to radiation therapy by getting them to exercise a little bit more? Here's the bike back again. But Matthew Beggs, my PhD student at Queen's, is looking to design a study to improve exercise in patients with lung cancer in a safe way before chemoradiation. This may also work by overcoming hypoxia in the tumour by getting blood vessels to open up to get the patient's metabolic rate up a little bit, improve their VO2 max, so to speak. So Matthew will be looking at that over the next couple of years in Belfast. Twinned with all these exciting developments in lung cancer here in Dublin and in Belfast, we have some exciting bits of infrastructure that popped up in the radiation ecosystem. This is the Michael Moriarty Research Laboratory, open to all universities and groups, led by Fiona, and that's beginning to get established and do some work there, which is fantastic, supporting the work at St. Luke's. We also have the IROG, Irish Radiation Research Oncology Group, led by Prof Sinead Brennan, and she's done a fantastic job at connecting clinical trials across the island of Ireland to say, how do we better run trials together? How do we make trials available to every patient near home as best possible? And this is a fantastic network that we're going to hopefully augment and grow over the next couple of years. And of course, we've got Cancer Trials Ireland, which I've been very delighted to take up the role of Vice Clinical Chair of. And this is a not-for-profit organisation which runs clinical trials for across all the cancer disciplines in the island of Ireland. And this is 20,000 patients accrued in total, and it really has brought a lot of reinvigoration to Irish clinical trials. There are a lot of challenges to running clinical trials in Ireland, and they're not easy to overcome, but I think with a really determined group that this group is and others, I think we will make a lot of progress, particularly over the next couple of years. And very finally, back to translational research in radiation oncology. And one of the things we have in Ireland, we've got many fantastic researchers who work in different research groups with different bits of equipment, but we're not all connected. And what we've done in October 24 is to bring people together to say, like, how do we create a translation radiation oncology network? We've set out the things we want to investigate, and that's the black side. We've also said, how might we do this? And this was done at Brook Lodge, and we're really looking forward to getting some funding through HAEA. So if anybody from HAEA is here, please, a bit of money wouldn't go amiss. So that's something you'll hopefully see a bit more of in the coming years. Very finally, I want to thank some people. I want us to thank Charles. Charles here in the front, and I think it's fair to say that I wouldn't be standing here in front of you as the Marie Curie Chair wasn't for Charles' efforts to really get that post up and resurrected. So, Charles, you did a fantastic job, and you really have done a fantastic homage to Donald's memory by getting that post up and going. You do a fantastic job as our clinical leader inside the network, but again, thank you to Charles. I want to thank the Advanced Radiation Group in Belfast and Queens, who really, obviously, was my foundation of my really more recent scientific career, and again to Alan, to Joe, and all the team there, many of them in that group, Connor, who's there as well, and Carl, and without them, again, I wouldn't have had any luck starting off, and I think it goes to show that team science is always a better way to go, so I want to thank the group in Belfast for that too. I want to thank my colleagues in the International Association for Lung Cancer. This is a group that's truly international. We meet once a year at the World Congress for Lung Cancer. This is the radiation oncologists. They're by far the most interesting group in the I've instance. And we some interesting characters from them. But we do have, beyond the fun we have getting together, we also really do design a lot of fantastic trials and bring a lot of science and new techniques to patients. And I also want to thank my team in Belfast, my clinical team, who really, over the years, have been a fantastic support to me. I've really enjoyed working. These are my lung cancer radiation oncology colleagues, physicists, and also Linda, who's there on the very left of the screen, who's our lung cancer specialist radiographer. They really have been a fantastic, they are a really good clinical team, and we were very blessed this year. We won the Northern Ireland Healthcare Award Oncology Team of the Year just as I was leaving, so no pressure to win that again next year, folks, too. Seamus McAleer. Seamus has been a fantastic mentor. He's been both scientifically, clinically, but also cycling. Whenever I started off in oncology, how I got into cycling with Seamus was he came. I was working in the ward. He was doing a ward now, and Seamus said very sternly, he says, "Was that you cycling on Saturday afternoon along the Hill Hall Road?" And I said, "Yes, Seamus, that was me." He said, "You're not allowed to cycle that road. It's far too dangerous." He says, "We're too short of registrars. If anything happens to you, we'll be too short in the ward. I'm going to show you where to cycle properly." And that's exactly how we got into cycling. So thanks to Seamus for that. And of course, to Gerard and to Jonathan. I think a lot of the work we've done together has been very impactful. It's been really fantastic. Gerard has done a brilliant job. He's been an ICAT fellow. He's also been a Fulbright scholar to the US last year. Congratulations, Gerard, a really fantastic achievement, and really shown how you really do an ICAT really brilliantly and really well. And the collaborations we have, I think, endured through Australia, it's endured back at Queen's, Belfast Trust, and hopefully we'll grow them even further now again. So thank you, Gerard. So really, what I want to say, from monotone to symphony, this is really going from doing black and white images to really a whole symphony of people doing lung cancer radiation research who have supported me, impacted me, and together we hopefully have changed the dial for patients with lung cancer. We hopefully made a difference, improving outcomes, providing more supportive care, providing more compassionate care as we've gone along. So it truly is hopefully a symphony of people. Very, very finally, I want to thank my family. This is my extended family. Missing from that photograph is my brother Greg. Greg has taken a few hours out of tonight for working at Greg Dog Whiskey. Greg, of course, who also is looking after the kids from time to time too as well. But thank you, Greg, for being here. I know that you've been really busy over the last week, so it means a lot for you to be here. This is my mum and dad. My mum, unfortunately, can't believe that she passed from ovarian cancer a number of years ago, but I think she would have been glad that I did go into research and hopefully made a difference for patients such as herself in the longer term. Very finally, to my immediate family, to Alice, Patrick, James, and of course to Susie, who's been with me all the way through this journey too as well. So thank you very much.
Take a break. Catch your breath. What can I say? I mean, well, you covered so much ground. I've never seen you. Definitely have increased the quotient of smiling, happy people in photographs. I have to say, everyone seems so happy, which is great to see. But thank you so much for really, I think, giving us such an in-depth look across so much, and to think you're only halfway through your career, so I can't wait to see the second half is going to be even better. So listen, I think Gerry has done an amazing job and really obviously put a lot of effort, time and thought into it, and we're very appreciative of that. So we're not going to take questions at this stage. Instead, we're going to let him catch his breath and invite you all to join the reception just out the door and down to the left, where you can carry on your conversations. I'm sure he'd entertain some questions if you have them, and be sure and congratulate him. Thank you all again for coming. Good evening.